Adam is associate professor at the Georgetown University Center for Children and Families. As an advocate with degrees in both law and public health, George successfully fights to keep health plans and hospitals nonprofit and community focused in North Carolina. He also helped pass North Carolina's Children's Health Insurance Program and worked for the passage of the Affordable Care Act. As with George Pink, the THCC is thrilled and honored to have Adam with us today. Adam, welcome.
Hey, thank you very much. And I want to first apologize for not being able to join you earlier. I'm actually, I work at Georgetown. I also have a adjunct appointment at UNC Chapel Hill in the same department as George does. And I live in Chapel Hill, North Carolina, so I don't live in DC. And I'm running for the local town council of Chapel Hill. So my weekends recently are filled with running around talking to people. That's what I was doing this morning. And so I apologize I wasn't able to join you earlier. And let me just say, I know that we have till 11:50, I think. Isn't that correct, Barb? Yeah, I think so. Yeah. So, and I also, because I wasn't able to join you earlier, and because I know George covered tons and tons of this, I don't want to sit here and repeat, and he's the expert. I'm not the expert in these rural hospital closures. So I think he is probably covered, if y'all can just, confirm this, but the fact that they're more, they're the basics of rural hospital closings and then some of the financing and stuff behind that. I think he's probably covered a lot of that much better than I ever would. Is that correct? That seems so.
Yes. Well, what we're hoping is that we'll have 10 minutes for Q&A as well.
Okay. Yeah. So, well, I will give you more than 10 minutes for Q&A, and I'm happy to sit here and answer more questions as much as you all like. So why don't and I've got a couple things to show you. So when I get started, so do you want to, how do you want to do this? You want to ask me questions, or you want me just to go ahead and give a little spiel and then?
Well, why don't you start, and then at about 9:42 Central Time, 10:42 Eastern Time, we'll start with Q&A. Does that sound good?
Yeah, that's fine. I think it's actually 12:40, but why don't we can even move that back?
Okay.
Eastern. Yeah.
Oh, sorry. I'm in Pacific. I'm way off. Okay.
It's hard with all the zooming going on. All right.
Sorry about that.
So first of all, I know you all have gone through some of this, so stop me if I haven't, but there's, just you're talking about Medicaid expansion and what effect this has in the debate around rural hospitals and rural communities and rural health. And I don't know how much Dr. Pink got into this, but just the reality is, and the research is, more rural hospitals, right, are closing in states that have refused the Medicaid expansion coverage. I think we're past debating that. Unfortunately, Medicaid expansion is probably the most studied health policy topic in the last 50 years or more, probably 100 years. And we have just reams of research out the wazoo that show if you're a state that's expanded Medicaid, here I'm looking in the chat, yeah, state that's expanded Medicaid, that there are huge benefits to the expansion, whether you're talking about more access to care, whether you're talking about, we've actually measured people's health status on multiple different areas and increasing health status, to things like that I've written about recently. Our group here at CCF has written about lower rates of maternal mortality, lower rates of infant mortality. It's just a huge list. If this was just a policy debate, the debate would be over. Every state would have expanded. I have to tell you, I was, for 17 years, I worked as head of the advocacy group in North Carolina, is much like yours. And actually, I worked with THCC. So, and I was pushing for better healthcare like you all do. When the Supreme Court decision came down, and I was still in that position that said Medicaid expansion is optional for states. And I wrote an op-ed that said, of course, North Carolina is going to expand Medicaid. Here are all the reasons why, and it's going to happen, within the year. There's no doubt in my mind. And here we are, almost like 8-9 years later, and it still hasn't happened. Every once in a while, someone dredges that back up and embarrasses me with it. So I hope nobody's planning to do that today. But I think, like, even back then, we knew that the numbers were good. This was more of a political argument. So I see that George was talking mostly about ER and stuff like that. But so let me just go over this. We have, I think there's been sort of 4 different things most recently. There's been a study from Chartis. There's been one in Health Affairs. The GAO did one. I can send some of these later, but overall, when you look at expansion states and non-expansion states, the latest 2020 study, I think this was this Charter study, says that rural hospitals are 62% less likely to close in expansion states. Okay, 62%. Then the top states that are where hospitals are closing, I wrote about this a few years ago. I think it's changed a little bit, but it includes Tennessee, Texas, Georgia, Alabama, Mississippi, North Carolina. These are all states that haven't expanded Medicaid. So the reality is that we know this has a significant effect. Now, I think we got to be careful, and I'm sure George was talking about this too, that this is not the only factor that is driving these closures. And I'm sure he talked about the finances and stuff. And there's a lot of challenges that rural hospitals have. But we do know, and that can be affected, like, you have to be careful of drawing these big generalizations from this data. There are other problems that hospitals in Texas have that are not related directly to Medicaid expansion that is causing them to close. The other thing, and we wrote a paper on this a couple years ago, is that in expansion states, when they expand, the percentage, so no duh, the percentage of uninsured people goes down, okay? But what we found in our paper is that the percentage of uninsured people in rural areas goes down more than the percentage in metros, okay? Small towns and rural areas. So Medicaid has a much bigger effect when you expand in these rural areas and small towns. It's not necessarily numbers, it just evens out this disparity between the metros and the small towns and rural areas. And why is that? Because in small towns and rural areas, you just have higher percentages of people who are lower income, who will qualify for expansion, and then working in places that, like the gas station, the, construction, convenience store, whatever, that are less likely to have coverage. So I'll just give you, sort of the overall data. Is that in the uninsured rate in Medicaid expansion states over roughly the last 10 years, and this is just pre-pandemic, like a lot of these statistics we have, the pandemic's messed them all up, but went from 35%, and this is with the Affordable Care Act too, which had a huge effect in expansion and non-expansion states, went from 35% to 16% uninsured rate in Medicaid expansion states in rural areas, okay, in small towns. Where a state didn't expand Medicaid, the Affordable Care Act still had an effect in these rural areas and small towns, but not as much. Uninsured rate went from 38% to 32%. So this is among lower income folks in these smaller towns and rural areas. So Medicaid expansion, giant effect. And that means that when somebody comes into the hospital that's in that community, they're going to be able to pay their bills, and that has a benefit, obviously. So I think that's something that's just really important to understand. Let's go and move to what are some of the other effects in expansion states. And then I'm going to show you a video, and we're going to talk about legislative changes, okay, and how this happens. I know I have been along with you all and watching for many years, just like in North Carolina, and I know how hard it is to change things in Tennessee. I'm not I don't have a rose-colored glasses on. It's easy. So first of all, the one thing that I did, and this was a few years ago, was while we were sort of in the middle of looking at expansion, non-expansion stuff. But I went and with a colleague and called up a bunch of rural hospital CEOs, CEOs of community health centers. I think George might serve on the board of the one here we have in town, which are great. I love FQHCs. I served on the same board a long time ago. And so, in an expansion state, I called in expansion states and non-expansion states, said, what are the differences? And it was so striking to me how in expansion states, when you talk to folks who are actually having to run these organizations and deal with their payer mixes and the competition with bigger, institutions outside of town, whatever, all these other things they deal with. One thing that there was a common theme, and which could be stressed more, I think, when this debate comes up, is that these folks running these institutions said to me, one thing, it's nice to get paid more and to have more of our payer mix, but one thing is some of that stress level coming down is allowing us to do more collaboration with some of our other institutions, whether they're bigger hospital systems or whatever, or somebody, the community health center and the hospital maybe working together a little bit more than they do now, because we don't have that same worry about who's taking the biggest share of uninsured patients. Okay, so taking that stress out a little bit, it didn't just help financially, but it also helped drive some of these collaborations. And I think that's a nice, we don't talk a whole lot about that, but it's more qualitative, but it's something that is an effect and that is helpful. Okay, let's talk about legislative changes and how this has happened in other states. And it hasn't been easy, that's for sure. I think there's a couple, and now I've worked in almost every single state that has expanded in the last few years, or has come close to, or has just said no way in heck, which unfortunately Tennessee, you are I think you might be in the no way in heck category. I don't want to overstep here. North Carolina seems to be that way too. There's rumblings that they might, but I kind of think they're the no way in heck. But one thing that if you don't have a ballot initiative like Missouri and Oklahoma and Nebraska did, or that we saw there, which we don't have that in a lot of the southern states. There's historic reasons with the English governors pre the American Revolution. We didn't like the English governors as much, so when we moved west, we were willing to put more of our faith in the people rather than in the English governor just doing everything. So you have more. That's one reason why you have that discrepancy. Going aside, but the things that have happened that have made the biggest impact are really legislative change. And I know that doesn't help very much to you in Tennessee, but Virginia was the key. We had like 3 or 4 rural legislators who did really flipped on this. And it was for 2 reasons. One, their folks in their rural communities just kept pounding at them. Here's what's going to happen. And here's, X in your community. This is how it helps her. Here's the hospital executives go. Here's, how this would help us. And, us, our hospital, our community health center. And when they flipped, these the couple of them flipped first on expansion, not party. I'm talking about expansion. And then that helped a couple more flip. And the Virginia, the legislature was very close at that point. And so what that meant was there was suddenly a much better chance that it was going to pass. And it was harder to just, stand in the, in the well or in the, the dam falling apart. It was harder to do that when it looked like it might become, more of a bipartisan campaign issue. And I know it's tough. You have a very tough environment in Tennessee, so I'm not trying to do that. But I do think it is still worthwhile to keep working on those rural legislators. You cannot give up. That is one way to do it. The other thing is, and I know, you went back and forth this, a strong governor really helps. Okay. It's even in a rural area. And I'm going to show you, I have an example I'm going to share my screen. So give me a second to do this. This is Governor Laura Kelly in Kansas. And I was at this forum where she talks about rural hospitals and Medicaid expansion with her. It was just a few months before the pandemic. I pulled this clip up and I was like, oh no, this makes me feel bad that we don't have substance freedom. No one has any masks on or anything. But take a look, listen to what she says about rural hospitals. You might have to turn the volume up. When she's talking at first, she's talking in response to a question about reasons why Medicaid expansion is helpful. And I upped the volume as much as I could, but you might have to up the volume a little bit more. It's only about a minute long. So let me pull this up for you. Hold on. And see if I can do this.
She would fall into the expansion category, and the feds would pick up 90% of that. We would pick up 10, another huge savings. And there are others. And not to mention the fact that the economy of growth, that's what's been found in every single state. When that happens, you have more jobs, more people paying into the system and providing more revenue so that we can broaden our tax base. So that's, I think, specific to rural hospitals, it is not a panacea. I'm not going to tell you that no rural hospital will ever close if we expand it. That's not true. There are a lot of other things that we need to do to ensure that that doesn't happen, which is why we created the Office of Rural Prosperity under the auspices of the Lieutenant Governor. So we're working on rural issues from a comprehensive situation, so we can work with our small communities, help them determine what their assets are, and help them put the system together that will help them grow and survive. So we're looking at Medicaid expansion as part of that process.
All right. So did you see, was everybody able to hear that? I apologize. It was coming. No, you couldn't. Was no one able to hear it? Well, let me tell you. So Laura Kelly, I'll tell you what she said in case you weren't able to hear it. So she goes, Medicaid expansion, very important. And what we're doing here in Kansas is we are, don't think that this is a complete panacea. There are lots of other reasons that rural hospitals close, but this is a very important one. What we're doing, I've assigned the Lieutenant Governor. We have this Rural Prosperity Task Force that is working with our rural communities to think about all kinds of issues that affect our rural communities. And Medicaid expansion is a top part of that. So if you didn't hear it, that's what she said. And she's a Democrat. She works with a very conservative General Assembly. And she got as close as anyone did, as any Democrat did over the last couple of years. But did you see what she did? So she was able to take the issue of expansion and put it in the broader rural prosperity context. And that is one of the reasons that she was successful. That's a great example because she did get a lot of Republican support for that notion. And that allowed some of her more conservative legislators who she's working with to come on board with her. It didn't help in the end. It was like a one vote away from doing it. But that was a very helpful strategy. So I think that's one thing I can do. The other thing, I understand about your governor. So I'm not going to show you another video that you can't hear, but I'm going to show you. Here's Governor Cooper from North Carolina. Again, this was a couple of years ago. And so he was having this roundtable discussion with executives with hospital executives, and he's done a lot of that. So it's similar to what Governor Kelly was doing to try and broaden the issue a little bit, talk about it in broader terms. All right, so we've covered that. We've covered the legislature. I'm gonna say one final plea, and I know you all are part of this and do a good job at this already. But the stories are critical of people who are in the gap, who are in this Medicaid gap. We emphasize this in our Together for Medicaid project all the time, but it is the single most effective grassroots work that we can do. I know you all guys are doing a good job with that. You folks are doing a good job, but I cannot tell you how many times in these different states that it especially, that when you take these stories and they're in the public eye, they really do make a difference. The other thing is, and I know you all are part of this too, but is those stories, the people who are telling those stories often are become some of the most effective advocates. They move up this ladder of engagement and say, I'm going to come to every meeting. I'm going to make my plea. So I will just say thumbs up to your story work, thumbs up. That is making a difference in these states. I know it's a long process. We still have, I'm like 7 minutes short before we're going to go, but I think I'm going to stop there and, say I'm happy to answer questions and whatever format and however you want and however you'd like.
All right. Thank you so much, Adam. And let me invite people to continue to submit questions to the chat or speak up if you would like. That's fine. But let's start by picking up on the point about putting the issue of expansion into the prosperity context. One of the findings in our rural hospital report was about community people's observations of the serious impact on the local economy when the hospital closed. That's well known within the communities that we visited. Can you make some suggestions about how other places, or how you would suggest that we make that context, the economic context, more visible to the larger state and to the legislature?
And you mean it's just, so you're saying it was so devastating in that community to have the hospital closed,
right,
and had such huge effects, but it's over here and maybe the legislator who's from there. So the legislator there does not really, the rep doesn't really care that much about it.
We were told in some cases by community people that when they realized the hospital was about to close, the first thing they did was call in the state legislators from that area. And they would say, first of all, don't talk to me about Medicaid expansion. The economic context is a local story, but we've not really succeeded in making it a statewide story.
Yeah, I mean, I think where I've seen it in a couple states that have done a little bit, who have taken some of that economic context broader, they've managed to find like a state-based foundation that was willing to put together some sort of report about this issue. And I think North Carolina's done that. I have to think if there's been like in Oklahoma maybe has done that. And take, but so that does two things. So one, if it's coming from like a more neutral source, like a foundation that's not directly involved in the newspaper and the back and forth, that can be helpful. And if it's something that, from somebody who's respected, then that can be helpful. And if it's put together with some money, then you can put together a report that gives you, maybe you get some more media about it. It becomes something that's, more widely distributed. That's my top of the head suggestion. Very tough to get these out of the local story. I think the other thing, remember this fellow, there was this there was a hospital closure a few years ago in North Carolina, and I think the mayor like walked from North Carolina to Washington talking about Medicaid expansion. He got a lot of national press for that. And statewide, it was, everybody knew about this for a while, and then, it went off. So that I think that was that's probably the most press I've ever seen from the, I saw 10, probably 10 statewide stories about how the economic effects that were happening in that community. And it was all because he was, doing this walk. So anyway.
Right. All right. Thank you. We appreciate how difficult this is. A question from our executive director, Judy Reutman. Can you talk about the federal solution to Medicaid expansion in the reconciliation bill?
Sure, that's a great question. So, so there are these states like North Carolina or Tennessee that don't want to help 2 million of their citizens. The residents get good health care, has huge disproportionate impacts on our Black communities, rural communities. There was a major issue in the Senate campaign in Georgia. And so now we have a big push federally to provide a federal solution to making sure that people in the 12 states that haven't expanded Medicaid get coverage. And that's being debated right now in Congress. It's part of this back and forth over this big reconciliation bill that is one of a number of health changes, including expanded sort of making coverage under the ACA cheaper, and then most that's in the news is Medicare dental vision coverage. So it's this, it's one of a laundry list of things that the Democrats are thinking of. What would happen is that if this bill passes, and the final form is up in the air, I think it's still up in the air whether we actually get this or not. But if it does, the most likely thing would be that starting January 1st, 2022, people in the gap in states like Tennessee and North Carolina would be able to sign up for a marketplace plan with very, either no or very minimal cost sharing. Wouldn't be as quite as comprehensive as Medicaid is, but it would be pretty good. And at least in the House proposal right now, we would do that for a couple of years, and then we would move. And during that couple of years, the federal government would be establishing a Medicaid plan that would cover everyone in these states only. It would be like a federal Medicaid option. And then folks would move into that Medicaid option, and it would be a permanent option. Now, there's a lot between here and there. You could have 2 years of this marketplace coverage, and then we fight about moving into Medicaid. The other thing that's happening is states that have already expanded, they are saying, well, there's two things. One, you don't want them to drop it because you don't want to shift all these folks off of Medicaid, which is great coverage. So that's part of the debate. I think overall, though, a very good chance of passing. The debate right now is, do we make it comprehensive and permanent, which means we move people into Medicaid within a couple of years, and that if you're in these marketplace plans, that plan is a really, really good plan. We might wrap around Medicaid benefits into it. So watch that debate. It could have a giant effect on what's happening, and it could also shift your work. You could end up trying to enroll folks in this plan. You could also be at a spot where you have your state. One thing I'm worried about, you'll have your state legislators and governor who don't like any people or their citizens getting health care. They might be trying to sabotage this. It seems crazy to think that this is something that politicians do. I don't want my people to get health care. I'm going to try and mess it up. But we've seen that again in these states. So watch what's happening. I am actually feeling pretty good that we might get something. There was just a huge amount of debate, but giant need to have happen right here. So yeah, I'd send the message. But that's where we are. I think it would have a huge effect. But don't give up on, you got to keep your other stuff going on, because this is Washington, D.C. We're not talking about any guarantees up there.
All right, thank you, Adam. A question from a member of our rural health team and a board member, Tracy Stansberry. Have you had an opportunity to study Tennessee's TennCare 3 proposal? We're wondering how you think it compares to expansion in terms of coverage for the uninsured and economic benefits to communities.
I have not had the opportunity to study it, so unfortunately, but you can tell me about it. And do you have like 2 sentences? And then I'm a lawyer, so I'm always willing to opine on stuff I don't know much about.
Tracy, let me ask you to step up here and say a little bit about it. Can you unmute yourself?
Can you hear me okay?
Yes, thanks.
Okay. Well, and I'm still learning a lot about it as well, but it's my understanding that, we've been told it's not a typical block grant, but that's still, I think, the fear of a lot of people in the state is that it has a lot of block grant features. And, it's our understanding that there will be a flexible cap, which seems a little odd or a little bit of a misnomer that there'd be flexibility in a cap. But so we've been told that, if there are needs beyond what the original max would be, that, the federal government would essentially contribute more money toward the program. But that's kind of what we know at this point. So
yeah, I'm sorry, I didn't realize the TennCare 3 is this block grant proposed, the state block grant proposal. Okay, I do know something about that.
okay.
I'm a complete ignoramus, so, but luckily, which is right. I do not know as much as Tracy does. I am sure about that, but I now know enough to pontificate about it.
Okay.
So I've remembered enough about it. So, first of all, the Biden administration is never going to let that through, right? So we don't have to worry about it for a while. If Biden loses, hopefully he won't lose. We've 8 years, so we don't have to worry about it because there's no way in heck the Biden administration is going to let a block grant proposal for Medicaid through. And this is a block grant proposal. It's not, I know they talk about this flexible cap. Block grant proposal mean the federal government gives a big chunk of change and says to the state and says, well, there are limits as to, if you give out more care than you do within that amount of money we gave you, plus the way to get above the cap a little bit, then too bad, you're on the hook for it. Which I always think with these proposals is so silly. It's like, well, what the hell are you going to do? People need the health coverage. It's not they're going to keep walking into the hospital. Plus, the other thing I think, if proposals like this, whichever flexibility you put on it or whatever, we just are coming out and hardly coming out of a giant pandemic where we had enormous changes in what healthcare people needed. And we have all these folks who are going to have long-term conditions for the rest of their lives, maybe after the pandemic. And so the idea that, that's a giant unknown. And the idea that we would say to a state, well, we're going to have this budget, and if you go over it, then too bad. The pandemic is I think, reason one why this is like it always was a dumb idea, but it's even dumber now. So one, not going to happen under the Biden administration. Two, if we do end up in a situation where it does, I think that we do have a bit of a changed environment where it's going to be easier to make the arguments against it, which were already pretty easy to make. Final thing I'll say about any of these block grant proposals, and I put this squarely in this room, is that every time they come up over the last 30 years, Congress has never allowed this to happen. And I know that the Trump administration was pretending that well, yeah, okay. They did this under the waiver proposal. There's an argument, you were absolutely right in the chat, that yes, that there was this argument that they did it, but it was such a huge amount of money. But what's happened is when there comes to, if you're going to try and make a change in Congress that is beyond the waiver proposal, I think arguably this TennCare 3 is not within the waiver authority of CMS. But when you try and make these changes, under a, in Congress to block grant Medicaid, it never works because the states all squabble about who's going to get the most reimbursement. They have the system they like now. The minute you try and make these changes, Congress never wants to do it, regardless of who's in charge, because every state, gets different amounts of money. It changes how much money they're getting. So everybody starts to fight about it. But yes, that's a good point. I should have said there was that other waiver that they allowed.
Yeah. Thank you, Tracy, and thank you, Adam. Another question, this one from Natalie Blocker. Will the new infrastructure bill address rural hospitals, and how so?
I really don't know. I'm sorry. I can look it up and I can forward it to you, but I apologize. I should know that. I don't.
Okay.
That's absolutely fine. I'm not going to judge you.
It's okay. Some people were asking me about a bike trail connection between their neighborhood and somewhere else this morning. I was like, I've got no idea.
Well, we're used to politicians who say they have an answer when they really don't. So we appreciate this. Thank you.
That is, yes, absolutely.
Another question that's come up as we've talked with rural residents in Tennessee is that one of the things that's happened with COVID that's further stressed rural hospitals is the issue of loss of staff members due to burnout, etc., or their movement to other places where they could be paid more, including switching their employment to traveling nurse agencies where they're paid quite a bit more. That means that the rural hospital, in order to keep staff, must pay the traveling nurse agency sometimes as much as 3 times more than what they would have paid a nurse or a laboratory person or something in terms of their salary. I'm sure this is going on in other parts of the country. I wonder if you could comment on this recent dynamic.
Yeah, again, this is a little out of my bailiwick. I've been reading those stories too. Yeah, I don't I mean, the first thing, I mean, it's just it just highlights, I think, to me, as someone who looks at, the health of hospitals and how we're paying for healthcare and stuff, they're just these enormous changes from the pandemic that we haven't really fully absorbed. And I don't have more this, the stress we're putting on our hospital workers, especially in all states, but especially states that have had these horrible outbreaks. And I know you all read the same stories I do about these, the deaths, and it's just so tragic. And I think I'm not going to talk about the providers I bike with or anything, but it really, like, I'm tear up a little bit. I mean, there are these just the amount of stress and what we're asking for our nurses and our doctors and the people who clean the hospital rooms and stuff. It's just sort of devastating. We're gonna have to think about it. And this example where you can't get nurses and you're paying these agencies gazillions of dollars to bring people in who are getting paid more than people who've been there for 20 years. It's just crazy. So I don't know. I don't have a good reason, any answer other than I think we really need to rethink a lot of the ways we do business in healthcare after this, when we can come out of it and not just expect that things are going to go forward as normal. And that's a great example of one of them.
Yeah. Another example of possibly the need to rethink is that, according to the Affordable Care Act, nonprofit hospitals have to demonstrate and document every year the community benefit that they provide, but for-profit hospitals do not have to do that. Do you have any suggestions on how to enable us to put some leverage on the for-profits to even consider their community benefit and document it?
That's a good question. And actually, I followed that very closely because early in my career, I worked on trying to force more that same kind of accountability from our nonprofit health insurers. And Chuck Grassley worked, to do this community benefit from nonprofit hospitals. I have to tell you, it's been a little underwhelming, even for the nonprofit hospitals documenting their community benefit. You know, you have a lot of hospitals that are nonprofit that may be public, and that, you know, we've let them get away with saying, oh, well, we serve Medicaid patients. Well, great. You know, that's a lot of people in your community. So what? You know, what else are you doing? So I think that for nonprofits, that we already have a ways to go to make those reports even better. How to get for-profit institutions to do more. We don't have the leverage that Grassley used to put that into the bill to keep your, you know, IRS, your status. Having to do that, you know, he had enormous leverage to be able to do that. So we don't have that leverage. In my experience, we can do it. Well, I'm trying to think off the top of my head here. This is going to be in a problem. I mean, I think the way that that I've seen as an advocate, back when I was more of an advocate than an august professor, is that we really used a lot more of the media, you know, trying to zero in on some of these hospitals that were not doing a very good job for their communities. I'm particularly thinking of hospitals that use liens on people's houses for when they don't, low-income people's houses, when they don't pay their, are not able to pay their bills when they come into the ER or get treatment. So that's, you know, that sort of public shaming is one way that works. We just don't, you know, there's not that leverage. I guess a state could make it as a condition of the hospital licensure, and that could be somewhere we could go. That would be another, you know, avenue that we might take. I think it's worth trying. You know, I think Grassley's, even though it's not working that great, I think, or well, it was, you know, it's doing more, it's pushing a lot of these community hospitals more than they might otherwise.
Thank you. Thank you. We just had a comment in the chat that hospitals groups together sometimes and hire professionals to develop these statements that are too general to offer much help. So this is the real world we're dealing with.
No kidding. Yeah. I mean, come on.
Let me take this opportunity to thank you, Adam. This is exactly the conversation we needed to have, especially following George's earlier presentation and Rich's. So it's just been a perfect presentation. We're so grateful to you. I also want to thank the participants this morning for your attendance and also for your excellent comments and suggestions and questions.